Well, welcome to this video on the subject of hemorrhage. So this whole video is about bleeding. Hemorrhage simply means bleeding. Now, if you think about it, bleeding means that blood must be coming out of somewhere, and blood is only found in blood vessels and in the heart. So blood can either be in the arterial system, the capillaries, the venous system, or the heart itself. So bleeding has got to be damage to blood vessels, unless in a relatively rare circumstance there's damage to the heart. So really, hemorrhage occurs when there's damage to blood vessels. That's when hemorrhage occurs. And this means we can break hemorrhage down into arterial, venous or capillary hemorrhage, and it's useful to do so. Arterial bleeding is when an arterial vessel is damaged or cut or torn. And when an artery is initially cut, what happens is the blood actually spurts out, pss, pss, because it's under systolic blood pressure. So you might be in theatre and the surgeon cuts through an artery and it can actually spurt out, and it can actually hit you in the eye. The blood can spurt out. But then after just one spurt or two spurts, what happens is the arterial vessel starts to spasm down and the spurting gets much less and it turns more into an ooze. So initially when an artery is cut, it will spurt out blood, but then fairly quickly you get a reflex vasoconstriction. And of course that reflex vasoconstriction is very good, because the more narrow the lumen of the arterial vessel, the more narrow the lumen is through which blood can escape. So it's a very important defence mechanism. So initially you get spurting, but in the systemic circulation the arterial blood is going to be oxygenated, so the blood is going to be bright red. So when you look in a wound, maybe a few minutes after it's been formed, you can sometimes see there's areas of darker red blood and areas of bright red blood. The bright red blood tells you that there's arterial bleeding involved. Then bleeding can be venous. Now when a vein is cut, the blood more oozes out. It depends how big the vein is, of course, but it's not going to spurt out because it's not under systolic and diastolic blood pressure. So you get a steady streaming of blood from veins. Now if a large vein is cut, of course you can lose a lot of blood quite quickly, but it oozes out rather than pulsates out. And the blood in the systemic venous circulation is more deoxygenated than the arterial blood, so the blood is dark red. So venous blood, much darker colour. Arterial blood, bright red. Venous blood, dark red. Then there can be bleeding from capillaries. So you can get oozing from a wound surface, and blood can ooze into the wound from capillaries. Or, as well as capillaries being cut, capillaries can be damaged by trauma, by blunt trauma. So if a tissue is impacted, then some capillary walls can burst, and that can allow blood to bleed out into the interstitial spaces. And you end up with erythrocytes with red blood cells in the tissue spaces. And that, of course, is what forms a bruise or a contusion. It's blood in the tissue spaces. So arterial, venous, capillary, pretty straightforward. Let's think now about forms of hemorrhage, and this is quite another useful area of thinking. Now, primary hemorrhage occurs at the time of trauma. So when a surgeon cuts, or when you cut yourself with a knife in the kitchen, or when a vessel is torn, at the time, the bleeding that occurs at the time of the injury is described as the primary hemorrhage. And blood can be lost through the primary hemorrhage, obviously. But then in healthcare we also have another type of hemorrhage called reactionary hemorrhage. And reactionary hemorrhage is hemorrhage which occurs in response to an increase in blood pressure. So what can happen is that the patient is at the scene of the road traffic accident. They might be bleeding internally or externally, and the blood can start to clot over the end of some of the blood vessels, sealing the hemorrhage, stopping the hemorrhage as the blood clots over the end of blood vessels. But by this time the patient's probably lost quite a lot of blood, so their blood pressure might be low. Then they come into hospital And because we're clever and efficient, we put up intravenous drips and we run in a litre or two of Hartmann's or normal saline, as indeed we're supposed to. But because we raise the blood pressure quickly, before we have established definitive hemostasis, then the rise in blood pressure can blow these blood clots off the end of the vessels. And we can get hemorrhage again in reaction to the increase in the blood pressure that I have facilitated. Or if a patient's in theatre, they're anaesthetised, they're not feeling pain, their blood pressure's low, their blood pressure's well controlled because of the anaesthetic, and the surgeon will clip up whatever vessels he sees, but some blood clot might have formed over a vessel that the surgeon doesn't see and doesn't tie off, or doesn't cauterise in some way, doesn't use his diathermy machine on. Then when the patient comes back to the ward, they start to wake up, the anaesthetic's worn off, they might be in quite a lot of pain, which can raise their blood pressure. They've probably got intravenous fluids going, which can raise their blood pressure. The blood pressure rises when the patient's back on the ward, and again that can blow off the blood clots, causing reactionary hemorrhage. And that can be quite a serious post-operative complication, which of course is why we do post-operative observations on all our patients. We're always checking for the possibility of reactionary hemorrhage. And in some cases, the patient might even need to be taken back to theatre to close the bleeding vessel. So, reactionary hemorrhage, hemorrhage that occurs after the primary hemorrhage in response to a rise in blood pressure. Not high blood pressure, even a restoration of blood pressure back towards normal levels, because the blood pressure's probably been low when the hemostasis was facilitated by the coagulation cascade at the end of the bleeding vessels. So primary hemorrhage, reactionary hemorrhage. Another type is secondary hemorrhage. Now secondary hemorrhage tends to occur several days after the primary injury, typically maybe 7, 8, 9, 10 days after the primary injury. And thankfully we don't see much of it now, but it is caused by the development of infection. So if there's an infection in a wound, that can damage the blood vessels and cause bleeding 7, 8, 9, 10 days after the initial injury. So secondary hemorrhage is hemorrhage which occurs in a wound secondary to infection. So primary, reactionary, secondary, pathological. There are many disease processes which can give rise to bleeding. So what I'm saying now is that, yeah, we know bleeding can occur as a response to trauma, obviously, but bleeding can also occur as a response to many different disease processes. And if you stick around for a while, we'll be looking at some of those on this video. So hemorrhage is damage to blood vessels. Can be arterial, venous or capillary. The forms of hemorrhage: primary at the time, reactionary to increase in blood pressure, secondary as a result of infection, and pathological as a result of some disease process. We're now thinking about the site of hemorrhage. Where does the bleeding occur from? And we can keep this simple by dividing it into three. First of all, hemorrhage can be external. That is, the blood leaks somewhere from the surface of the body, so is usually fairly obvious. Or you would think it was fairly obvious. This is why in emergency situations, after we've looked at A, B, C and D, we have to E, which is expose the patient. After airway, breathing, circulation, disability, E is for exposure, because we want to look all over the surface of the patient's body. Because it's quite possible that the patient could be bleeding and a pool of blood could be trickling down somewhere and collecting in their back or in their buttocks or somewhere that you don't see, or into a boot or something like that. So you think external hemorrhage is obvious, but always be sure in a trauma situation that you've examined all of the patient's body surface area and identified any external hemorrhage. But 99 times out of 100, you're right, external hemorrhage will be pretty obvious. Then hemorrhage can be internal, bleeding into the organs or the cavities of the body. So blood could go into the pleural space or the peritoneal space. Now normally these are potential spaces, but they've got the capacity to become actual spaces filled up with blood. And this is an example of what we call third spacing of body fluids. The fluid's not in the intracellular fluid, it's not in the extracellular fluid, it's in a third space where it shouldn't be, and it can collect. And obviously if the blood's collecting in the chest or in the abdomen, or from a fractured femur where you can lose an awful lot of blood, then that blood, because it's stagnant and in one place, it's lost to the circulatory system. Therefore it can't contribute towards tissue oxygenation, and it can't contribute towards the maintenance of blood pressure. It's collecting in some internal place. But there's a third classification it's useful to think about, and that is revealed hemorrhage. So revealed hemorrhage starts off internal, but then reveals itself. We come to see it as it reveals itself. So for example, there might be bleeding into the stomach, and then the patient vomits. And when the patient vomits, we see the blood. The blood becomes revealed. Or there might be bleeding into the rectum, and then the patient opens their bowels and we see the blood coming out of the anus. It becomes revealed. Or there might be blood leaking into the lungs. Then the patient coughs and we see the blood in the sputum. It becomes revealed after the hemorrhage has occurred. So sites of hemorrhage, simply put, external, internal and revealed. Simple but quite important to know. External, internal or revealed forms of hemorrhage.